Dr. Lalita Prasad-Reddy obtained her PharmD from Creighton University and her Master's in Health Communication from Boston University. She's also completed a PGY1 and a PGY2 residency at the University of Chicago and then Indiana University Health. Dr. Prasad-Reddy is the Assistant Dean for Pre-Clerkship Education at Rosalind Franklin's Chicago Medical School and a clinical pharmacy specialist at Rush University. She is also the past chair of ICHP's DEIA committee. Thank you so much for being with us today, Lisa.
Thank you, Melissa, for that kind introduction, and thanks for everybody for joining today. So we're going to talk about implicit biases and its impact on pharmacy practice. And so this will be available for home study, and it does satisfy the implicit bias CE requirement that is required for state relicensing. So there are no conflicts of interest with ineligible companies that I need to disclose. The learning objectives for today's sessions are to compare and contrast implicit and explicit biases by level of awareness, intentionality, and influence on behavior, outline how implicit biases develop and the cognitive and societal factors that contribute to their formation, examine the impact of implicit bias on equity, patient safety, and professional interactions, and describe strategies to recognize, interrupt, and mitigate implicit bias. Now, one thing that I always start with is basically setting the tone. So, when we're talking about these topics where there's a spectrum of perspectives on how people feel, it's important to adopt a mindset that can work through discomfort and view mistakes as learning opportunities. So, you may not agree with everything that I'm saying today. I will just share some data and I will share what is known about implicit bias and how it penetrates patient care in a negative fashion. But really just understanding the binary mindset that this is not, if you don't agree with this, that doesn't make you bad. There's not a good person makes bad decisions and a bad person makes good decisions. It's possible to act with good intentions and still perpetuate systemic bias. And so that is what really the tone here today is that really we need to focus on the impact that we make on others, not necessarily our intent, because we know that we all make mistakes and it's important to be open to helping others recognize mistakes and view mistakes as learning opportunities. We all need to start with ourselves to foster a more equitable, inclusive, and bias-free culture in healthcare. And so that starts by setting aside time for feedback and reflection. And when making reflections, not be accusatory to others, but really focusing on I statements in terms of what could I do to make a better impact and enhance patient care and eliminate my own biases. Allow yourselves and others to learn. So challenge a colorblind perspective. So challenge that, challenge those current perspectives that you have and just adopt a growth mindset. Recognize that you may be uncomfortable, but only with somebody being uncomfortable does growth really occur. And learn how bias operates and then call it out when it occurs. So in order to start, I'm going to just give you an individual reflection. So when you think about what diversity, equity, inclusion, and I'll also add accessibility, DEIA, mean to you, just take a moment and think about that. And what initiatives have you developed at your institutions to enhance these efforts? Now, the reason that I think it's important to start with this is because fostering an environment that encourage individuals to face implicit biases, recognize their own biases, and work towards eliminating and mitigating those biases is really fostering equitable care and really making fostering a more inclusive environment. And so when you do work towards identifying your own implicit biases and mitigating those biases, you are really fostering more equitable patient care across the spectrum. So I think it's important to recognize that when we talk about biases, there's, 1,000 different biases that exist. This quote specifically talks about racist biases and racism, but it can be applicable to all kinds of different areas. But I think it's really impactful. And then it just shows that facing our privilege is basically facing our biases. So I'm not racist, but I have racism in me. So saying I'm not biased or I'm not explicitly biased, but I have biases in me. And that is a very natural and human approach. So this is an author, Glennon Doyle, and I'm going to just read this quote because I think it really encompasses this idea of while I don't think I'm this way, I do live with these certain thoughts that may portray biases. So we all need to address our own situation, our own privilege, and the ways in which we've benefited from systemic inequity, but we need to do so in a way that doesn't harm the movement or interfere with voices that need to be heard. And I removed systemic racism and Black voices just so that it's applicable to all populations. So we enter race conversations far too early and we lead with our feelings and confusion and opinions. When we do this, we're centering on ourselves, so we inevitably get put back where we belong, which is far from the center. So essentially, again, this quote is just saying that we all have biases. We may not say that I'm racist. We may not say that I'm homophobic. We may not say that I'm, anti-immigrant, but we have our thoughts and our perceptions that maybe lead to the way we act and maybe lead to inequitable care for our patients. So this is a review of the disparities that exist in healthcare. So we do know that, there are different aspects in terms of the social determinants of health that lead to one's health outcome. So we are all born with the ability to have the pursuit of life, liberty, and the pursuit of happiness, but yet not of all of us have all equitable resources in order to achieve that status of health. And so when we think about the social determinants, it's really thinking about this disallocation of resources that really are fostered to more represented and privileged historical communities and kind of unequivocally moved away from those populations that are underrepresented in the United States. And so we do know that certain populations have less healthcare access, specifically when we think about racial minorities and racially underrepresented individuals who identify as Black or Hispanic typically have less healthcare access than historically privileged populations. We know certain populations utilize the healthcare system much less, and this would be racial and ethnic minorities, those individuals who identify as LGBTQIA+ because of fear of stigmatization and discrimination in the healthcare encounter, individuals living with a disability, immigrant populations, those with a history of incarceration, again, largely due to the fear of discrimination and stigmatization within the healthcare encounter. We do know that some of the more historical and foundational social determinants of education, socioeconomic status, housing, access to community resources, access to jobs, transportation, public safety, and so forth are all going to have a role in terms of one's ability to achieve their ideal health status. Now, something to recognize here is this is what the government identified as the major social determinants of health. And in the last couple of years, they have included discrimination and stigmatization to actually be something that is considered a social determinant of health. Because we know that patients that have historically had discrimination or felt biased against in the healthcare encounter are less likely to seek referral care, less likely to have confidence in their physician or the healthcare provider's recommendations, and are less likely to have optimal health outcomes. And so why I've included this here is it's important to recognize that implicit bias as a form of discrimination should be considered a social determinant of health. So some of the examples of healthcare disparities that exist in the United States are that LGBTQIA plus individuals face health disparities linked to that stigma and discrimination. So they have a higher risk of mental illness, a higher risk of infectious disease, and once those differences are accounted for, they actually have less quality of care. We know that there's a higher risk of chronic disease and chronic conditions conditions such as hypertension, cardiovascular disease, and diabetes in individuals who are living with a disability. And we know that certain ethnic and racial underrepresented populations also carry a higher burden of chronic disease. So we know that individuals who identify as Black, as Hispanic, or individuals who are indigenous populations have a much higher burden of cardiovascular disease, diabetes, and respiratory disease in the United States. One of the most prime examples of this was in 2020 when the COVID-19 pandemic had a disproportionate burden on individuals who identified as Black or Hispanic. And so here, if you look at health disparities, you can see that that these health disparities and inequities largely exist within populations that are historically underrepresented. Again, giving way to the idea that the social determinants and the allocation and the resources are large predictors in one's ability to achieve an ideal health status. So these are just some of the ways that systemic inequities can penetrate healthcare. So certainly implicit bias and microaggressions that exist from the healthcare provider or practitioner towards the patient, a decreased number of minority professionals. And this, again, is an artifact of implicit bias. So we know that the Black individuals and individuals that identify as Hispanic make up approximately 30% of the United States population, but they make up only about 13% of our healthcare providers, our professional providers. And when you think about that, we do know that individuals that are historically underrepresented, many of them have a preference to see somebody that looks like them, that understands the shoes that they've walked in. And so we need to do better about routing underrepresented populations into those healthcare professions. There are certain practices that we do here in our country based on calculations and calculators and algorithms that lead to bias and penetrate bias in the systemic, from a systemic perspective, and then certainly the social determinants of health. So let's delve into implicit bias. So implicit bias is a prejudice in favor, or typically when we think of implicit bias, we're thinking about against one thing, a person or a group, compared with another, usually in a way that's considered to be unfair. So it is a stereotype, an internal prejudice against a population or a person. Biases can be held against an individual, against a group, or an institution, more often have negative consequences, but can ultimately rise up another population. So when biases exist towards a racially underrepresented population, it tends to advantage your traditionally more privileged populations because resources, again, and preferential treatment is allocated towards that population and taken away against another. So the truth is, implicit biases don't make you bad. They just make you human. We all have them. They live within us. And so we just need to be able to recognize them and dismantle them so we can ensure that the biases that we have do not affect the way that we encounter and communicate with individuals and the care that we provide. These are all results of our cultural conditioning, the ways that we've been brought up in, our educational institutions, and the environments that exist around us. And ultimately, why is it an implicit bias? Because at the conscious level, these often are in conflict. So we may say, I don't believe that X is this way, but ultimately, implicitly, you do believe that X is this way, but you are not aware of it. And so when you have implicit biases, when you're not aware, ultimately that can lead to differential care. Now, it is important to recognize the difference between implicit and explicit bias. So implicit bias are going to be preferences, stereotypes, and prejudices that we are not aware of on a conscious level, whereas explicit bias is going to be explicit and outwards discrimination. So a good example would be, racial slurs. Those would be an example of an explicit bias where it is very outward in the open and it's at your conscious level that you feel that way. But bias exists on a spectrum. And so we have, again, this is listed as systemic racism, but it really could be systemic inequities because these are inequities that exist within our structure of our institution. So, for example, one example would be a lack of healthcare access that exists in certain areas. And this is due to redlining and segregation that occurred decades ago. But the consequences of the redlining and segregation did not only penetrate immediate generations, but now are affecting the health conditions of generations of 3 generations that are living after the civil rights movement. Institutional bias exists at the institutional level. So the educational system, the prison system, and most of us in healthcare go into mission of healthcare because we have an altruistic mission and we want to do good for others. We want to care for others and advance somebody's health and wellness. But it is thought that the healthcare institution can be one of the most discriminatory and biased institutions that exist in the United States. And you can just think of an example of that being the healthcare access and healthcare coverage. There is very differentiating levels of healthcare access and healthcare coverage that exists based upon your socioeconomic status. So if you're a patient that gets their medications through Medicaid, you often aren't going to get the same level of coverage and the same medications as somebody that has the ability to pay for private insurance. Interpersonal racism are those biases that exist between individuals. So that's where this implicit bias and explicit bias and racism occurs. And internalized is where individuals who have been discriminated against or stigmatized against start to internalize those feelings and start to believe them. So everybody treats me this way. Everybody says that this is a hallmark of the population that I represent, so I must be this way. So it's where you're turning these explicit biases and you're starting to believe that they are true. And that can be very, very damaging. So in order to start off and get deeper into with this implicit bias section, we're going to start with a true-false question. So would this scenario be considered an implicit or an explicit bias? A family practice practitioner has a clinic which sees patients of all ages. Maya, an 86-year-old female, states that in her past few months she feels lonely, has less energy, and feels apathetic at family gatherings. She complains of anhedonia and decreased appetite. The pharmacy resident asks the physician about the potential of treating Maya's depressive symptoms, and the physician responds, "It's a normal part of aging. I see it with everyone." So in this case, this would be a good example of implicit bias, specifically an ageist bias, right? Where you just assume that depression, anxiety, loneliness, and anhedonia are just representative of older populations, so you don't dig deeper. Where in this case, there could be something seriously concerning about Maya's behavior that we need to dig into. So biases form on all different levels, and they are a result of our cultural conditioning. So our environmental exposure, the friends and relatives that we're around. We always say inequities, racism, and bias starts at home. And so for children, they learn those biases from their environment. Past experiences. So if you had a negative experience with one person and then now you attribute it to their entire race or their entire ethnicity, then you are starting to cultivate that bias. Your societal experiences and how society portrays individuals. So how are individuals and populations portrayed in the media? How does the news outlets depict them? What do our leaders say about populations and our cultural experiences? So, which of the following would play a role in the formation of implicit biases? Past encounters and experiences, practice of mindfulness, family upbringing, or A and C? We can close the poll. So in this case, everybody, 100% of the individuals got it right. And it is correct that it is A and C, because we know that past encounters and experiences and family upbringing are going to be pivotal in actually increasing the formation of implicit biases, whereas a practice of mindfulness and counter stereotypics are actually going to be beneficial in mitigating and attenuating the impact of implicit biases on patient care. So there's several different types of biases that exist. We're not going to go into all of these that exist. There's thought to be over about 1,000 different biases that exist, but I am going to, walk you through some of these. So affinity biases, we tend to think that individuals that are more like us is the correct way to represent or the correct way to think. So, if you think about an affinity group, you tend to think or the same way or have the same preferences, but that could be looked at as a bias. An anchoring bias is this tendency to rely on the first piece of information that's present. In the United States, it is very apparent that there is a beauty bias, and so that individuals who are thought to be more externally attractive tend to have more advantages and opportunities in life. Confirmation bias, which means you agree with me, and therefore I'm going to be biased against somebody that disagrees with me. A contrast bias where you have, you are looking at two things differently and comparing them to each other rather than attributing them to their individual parts. We know that a gender bias exists in the United States, and gender bias has been called out a lot more recently in terms of hiring practices and educational and promotion opportunities for women. A halo bias, which really focuses on the positive features of an individual, believing that they are all good and they can't have any bad, versus a horns bias, where you're focusing just on the negative aspects of an individual and their negative attributes. So here in the United States, there are several different factors that are prone to bias. And what you can see on this slide is, if you really dig into it, is that what makes you prone to bias is to be underrepresented in that population. So age, if you're on any of the spectrums of age where you're younger or you're considered an older adult, you are at the risk of ageism. Body habituous, so we do know that in the United States, there is a very pro-thin, anti-obese, anti-overweight bias that exists that penetrates healthcare. Individuals who are a racial or ethnic minority or a person of color is more likely to have bias against them. Individuals living with a disability, a lower economic status, individuals who have a gender identity that doesn't represent cisgender and heterosexual. Immigration status. So if you're an undocumented immigrant or an individual who is documented but still an immigrant, they tend to also be prone to more bias. Individuals living with mental health conditions, substance use disorder, from a nation other than the United States, as I mentioned, an underrepresented racial or ethnic minority. If you are a religion outside of one of your five kind of mainstay religions, or a religion that is outside of the whatever area you're in that is dominant in that religion, substance use history, and again, sexual orientation. So implicit bias is essentially categorizing people without realizing it. And we do this. We do categorize people, and we essentially reduce their identities to a population. We say that person is this way because of this, rather than recognizing this concept of intersectionality, that every individual has different lived experiences and backgrounds that give rise to a very unique individual experience, and we need to respect that. And so instead, we typically reduce individuals to a unifying characteristic and assume that they act in whatever stereotypical and prejudiced way we believe is representative of that population. We do know that implicit bias is automatic and unconscious. It's a reflective response, and it begins at a young age because of repeated reinforcements. So one thing is to kind of practice this is to think about this activity where you hear the words strong, charismatic leader, what comes to mind? And when you hear the words a caring, compassionate, and sincere worker, what comes to mind? So if you are like 80% of our population, when you think of this word, this characteristic of a strong, charismatic leader, the first image that you would have seen would have been a male. And if when you heard these words, a caring, compassionate, and sincere worker, the first image that would have came to your mind would have been a woman. And so these are biases, because why can't a strong, charismatic leader be a man? And why can't a caring, compassionate, and sincere worker, why can't a strong, charismatic leader be a woman? And why can't a caring, compassionate, and sincere worker be a man? So these are just examples of how our implicit biases penetrate our everyday thoughts. So what implicit bias have you observed or experienced in healthcare? Have you seen tailoring of medication therapy based on the race of a patient, a lack of access opportunities to specialty providers based on socioeconomic status, a patient request to see a different practitioner based on gender or age, more than one of the above, or none of the above? We can close our poll. And, many of the individuals have probably seen that they've seen more of many of the above. So tailoring of medication therapy based on the race of a patient is a very common practice that we do unknowingly here in healthcare. A lack of access opportunities to specialty providers based on patient socioeconomic status is very common, oftentimes because specialty referral is pricey. So your access to all specialty providers is going to be limited based upon your socioeconomic status. And a patient requesting to see a different practitioner based on gender or age, that would be a bias. It is very common for patients to say that a provider looks too young and they can't be their doctor, and that they may want to see someone older. Now, and in terms of implicit bias among healthcare professionals, I think it's important to recognize that there's a lot of data that's been done on this that shows that explicitly individuals do not say that they preference one population over another, but when they take the implicit association tests and they're really forced to think about how they associate individuals with characteristics, it shows that there are implicit biases towards one population. So there was this first study showed that, individual among primary care providers and community members, it analyzed whether there was implicit or explicit bias against individuals that existed as that identified as Hispanic or Black in our community. Physicians showed a moderate pro-white anti-Black bias and a moderate pro-white anti-Hispanic bias, even though explicitly they said they treat all patients the same. The second one is really kind of shakes you a lot. So in a weight management clinic, for individuals who work in a weight management clinic, they determine the level of anti-fat bias. And it was found that health professionals working in a weight management clinic exhibited a significant pro-thin anti-fat bias. When you looked at implicit and explicit attitudes towards individuals that identified as lesbian or gay, among individuals who are cisgender and heterosexual, implicit preferences favored heterosexual people over individuals who identified as lesbian or gay. And then implicit preferences were weaker for heterosexual men. Explicit preferences for heterosexual versus lesbian and gay individuals were weakened than implicit preferences. And then in this study that evaluated providers' explicit and implicit attitudes towards individuals living with a disability, while explicitly they said they indicated little prejudice, their implicit attitudes revealed that they preferred individuals not living with a disability. So they believe, they were kind of focusing on this ableism attitude that individuals living with without a disability are more capable than individuals living with a disability. Here, this study, I'm not going to go into the details of it, but you can see that these implicit attitudes start early on. And so when you look at the implicit bias among healthcare trainees, you can see that there are implicit biases with an underlying preference towards individuals who identify as Caucasian, that cultural biases demonstrate that race students prefer, have a stronger preference for individuals who are light-skinned over dark-skinned, and that individuals express some explicit bias and implicit bias towards individuals who identified as LGBTQIA+. So why does this matter? Well, it's really important for us to face our biases, because if we possess biases, we are more likely to be less supportive of our patients, spend less time with our patients because we get very dismissive of their thoughts and concerns, exhibit less of a focus on thorough decision making, exhibit a higher risk of burnout because we don't find joy in our work anymore, because we are reducing all our patients to a stereotype and not developing strong relationships. Possess negative interpersonal behavior towards our patients. We are less likely to refer patients to specialty care or provide quality care. From a patient perspective, when you've lived through a biased patient encounter, you are less likely to be satisfied. You are less likely to trust that your provider or your practitioner had your best interest in mind. So there's less adherence with those recommendations and more distrust in the healthcare system, less confidence in treatment plans and clinical decision making, more likely to be lost to follow up again because you don't feel like those providers heard you and understood you. You might postpone your access to care, and ultimately this leads to unsatisfactory healthcare outcomes. Some of the examples of bias and systemic inequities and racism on health outcomes is that, there are these thought processes that typically penetrate our healthcare system. So there is, these biases that individuals who are Black don't need as much pain medications because they have less sensitive nerve endings. That has never been proven. And so there is undertreated pain control. Patients who are of darker skin are more likely to be blamed for being passive in their healthcare. And when they get diagnosed with chronic disease, it is more likely their fault. Hispanic patients are less likely to receive pain medications when they're prescribed. They occur at lower doses. Individuals who identified as Black are less likely to receive evidence-based care for stroke, myocardial infarction, and heart failure, as well as chronic kidney disease. For individuals who are elderly, they are less likely to receive adequate care for suicide prevention, mental health, anxiety, and depression. Women are less likely to be referred for total knee replacement than men. And then individuals with disabilities are often needed to work at a rate that is much, much more, at a rate that work twice as hard as their able-bodied peers for acceptance, and their struggle with stigma and microaggressions. So one thing that I think is important to do is to consider how to mitigate implicit bias on a more global scale. And this can begin in your pharmacy departments. The implicit association test is the most commonly used effective tool for measuring implicit bias. It's available. It was developed out of Harvard. And the idea behind this is the examinee is given a list of words and pictures, and they're and the words and pictures are divided into differing categories, two contrasting concepts, young and old, and two contrasting evaluations or stereotypes. And the faster that a prejudice or an attitude is matched to that contrasting concept, the more likely that bias exists. So for example, if you had young and old and you put athletic and unathletic, and you put young for athletic, old for unathletic, you matched those terms. And so that demonstrates how that you are more likely to think a young person is more athletic than an older person. Upon completion of the test, the examinee is provided with their results and an explanation of an identified implicit bias. Now, implicit association tests can be done anywhere, but it is really important to do this in a safe setting because oftentimes, as we've mentioned, our implicit biases are in contrast with our explicit preferences, and so it can be uncomfortable to navigate. And this can divulge info about bias, but it doesn't examine those behaviors. So it is important for from a cognitive dissonance perspective, from a cognitive dissonance perspective, to stay in the uncomfortability. So growth does not come without discomfort. So, when you're going through these ideas, it's going to be an emotional state that doesn't sit well, and that is intended to be there because if it doesn't sit well, that's when growth will occur. So some global threats about implicit bias, obviously we've talked about the patient care. From the admissions processes, we know that there's a lot of bias that goes into pharmacy school, medical school admissions, and individuals who are on your application screening team, your admissions committee, are involved in admissions in any way, they should be required to undergo implicit bias training. So there was a study out of the University of Minnesota where they had all of their individuals on the admissions committee undergo implicit bias training, and the next year they had their most diverse class in history. Making sure that we are making space and giving opportunity for promotion and hiring, and then making sure that we're doing things to route underrepresented populations into the workforce. All individuals need to know the pervasiveness of implicit bias among the healthcare system, the purpose of implicit self-assessments like the Harvard Implicit Association test, how to use them, how to interpret the results, and how to do this navigation of these perspectives with a trained facilitator. How implicit bias affects patients and their interactions with healthcare professionals, and how to apply these techniques for mitigating the effects of implicit bias. Now, once you have knowledge of your implicit biases, then you need to do the work in terms of the control strategies to reduce the presence of that bias and to reduce the way that it penetrates how you interact and communicate and work with patient. So you can think about using introspection, so stopping yourself, giving yourself reflection, mindfulness, perspective taking. So if I walked in that person's shoes, what would my thoughts be? Learning to slow down and be mindful and be in the moment. Individuation, so seeing a person for who they are, not reducing them to a group or a quality. Check your messaging. Think about how you communicate with individuals. Institutionalize fairness. So say in every encounter, how do I make sure that I'm giving equitable care across the board? And take two. So I don't think that appropriately and adequately implied what I wanted to say. Give me a chance to take two and let me rephrase that. Now, microaggressions are something that occur on a daily basis, unfortunately, and these are brief and commonplace indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative slights and insults that can have harmful and unpleasant psychological impact on the target person or group. So it's usually individuals possess or portray microaggressions because they have this inability to talk about race, racism, structural racism, racism, inequities, discrimination in a empathetic and emotionally appropriate way. They are often used to influence one's power. So to demonstrate that I am the power holder in this situation, and they contribute to the persistent disparities faced by marginalized groups. So it is important to think about microaggressions, specifically when we're working with learners. Because microaggressions and implicit biases can be learned behavior. So when an individual has a preceptor and that preceptor exhibits biases and exhibits microaggressions towards other populations, oftentimes those thought processes and those behaviors can be trickled down. And that's kind of called the hidden curriculum, where students learn these behaviors and these perspectives from individuals that they respect. So it has this potential for cumulative effects where we perceive minimal harm and we think that, oh, I'm just saying this and it's not going to be trickled down, but one person teaches another that teaches another. So when you are on the receiving end of bias or a microaggression, you want to think about approaching the speaker and, role modeling the response. So asking the speaker to elaborate on what they meant to help understand a perspective. So what makes you believe that? And avoid why questions or making that person go into a defensive mode. So demonstrate understanding reduces defensiveness. So let me just understand. So this is what you're thinking, or this is what you're saying, or reframe it. Allow for a different perspective and help that speaker uncover unconscious bias. So I'm wondering what message this is sending to that individual. Do you think you would have said that if this person was XYZ? And communicate the impact of the situation. So recognize that most individuals are altruistic and they don't mean harm, but describe the impact it had on you. So even by saying that, I don't think you meant any harm by saying this. However, as a person, I felt like this. And express your preference and revisit those. So the last thing that I kind of want to go through is these ideas, and an example of implicit bias and how it penetrates healthcare. So racial essentialism is one of these ways, one of these scientific racist philosophies that ultimately has, been carried down over several decades and over several centuries. And it is this idea that races are biologically different groups, even though the truth shows that we are 99.5 to 99.9% identical, and there are no identifiable genomic clusters. However, race continues to be used as a biological reality. The cold, hard truth is that racial differences found in data sets most likely often reflect the effects of systemic racism and inequity, not race. So when you think about the concept of race, so the concept of race was something that was developed back in the colonial times to keep power, hierarchy, and resources with the colonists and use individuals who are darker skinned colors to defend the practice of slavery. So this is where this idea of race originated. So it was back in the 16 and 1700s, and it was this social construct that basically artificially divided populations into those that would hold power and those that would not have power based upon physical appearance. Now, racism is basically taking that physical appearance that you have a dark skin color, you have a light skin color, and then artificially subordinating members of this group, or members that have relatively low social power, into the actions of individuals, cultural norms, and society, and reinforcing institutional structures. So this concept of racism, essentially evolved from this artificial concept of race. So there was no biological concept of race. Individuals who are Black have 99.5 to 99.9% same racial and DNA identity as an individual who is white or Hispanic. But these races are artificial depictions trying to underline the the idea that one population should hold social power while another shouldn't. Regardless, and now that we know that, 99.5 to 99.9% of our DNA is identical, and actually there's more differences in DNA in one population of the same race versus populations across races, we still practice scientific racism. And scientific racism is this idea that research characterizes race as a biological essential variable. So it basically says race is biological. But hypotheses involving race are largely implicit. They rely on this conventional wisdom that people from different races are genetically and biologically different. And we know since the Human Genome Project that that is not the case. We are 99.5 to 99.9% identical, and race is a social construct. Still, we practice race-based practice and implicit bias on a daily basis. So an example here is this 60-year-old white male. He comes in with diabetes, presenting to his primary care physician. He has a serum creatinine of 1.3 and a GFR of 56.3. Well, a 56.3 mLs per minute GFR would put him at stage 3A chronic kidney disease. So the electronic health record flags this patient, and our primary physician submits the referral for a patient to see the nephrologist. Now, when we go to our next patient, JK, you have the exact same patient in terms of patient profile, a 60-year-old individual with a serum creatinine of 1.3. The only difference here in these two patients is this individual has Black skin. Because they are classified as a Black patient, there is an artificial adjustment made to GFR calculation, where it says that because this person who is Black is more likely to have serum creatinine, a higher serum creatinine because of a higher muscle mass than an individual who's white, they're going to have an artificial elevation in their GFR. Well, their GFR is 68.2, which would mean that they do not have a diagnosis of chronic kidney disease. And so what these practices have led to is this underdiagnosis of chronic kidney disease for individuals who are Black, who have a higher risk of developing CKD to begin with. And this has led to less specialty referral to nephrologists, a delayed need for transplantation, and a delayed initiation of potentially kidney-saving medications. And so really thinking about the automatic practices that we utilize and how those can bias against one population is also going to be really important. There are several different clinical calculators that exist out there that utilize race as a biological variable, and we really need to think about if that is appropriate or not. Because when we practice with a race-based philosophy, we promote racial stereotyping. We reduce that research into biomarkers that are predictive for disease, and we condone false notions about different ethnicities and races, when in fact, again, we all share 99.5 to 99.9% of the same DNA. So there's really only one race, and that's the human race, because we are all very, very similar. So we do need to think about how we practice. We certainly don't want to practice in a race-based approach, and we certainly don't want to practice in a race-blind approach, because then we are negating that certain structural hierarchies have led to the discrimination that exists. And we do know that things like redlining, segregation, discriminatory practices towards underrepresented populations in the 90s in the United States lead to these systemic inequities that exist in healthcare. And so we really need to be thinking about an equity conscious mindset. So from a racial perspective, try to avoid using racial descriptors in the HPI. Include racial and ethnic information only in the social history. Explain to patients why it should be used, and mention physical characteristics such as skin tone rather than race in the physical exam if required to describe that finding adequately. So practicing in a race-conscious manner would really be thinking about questioning race-based analytic, thinking about how we present patients. Oftentimes when individuals who are Black or Hispanic are given more negative terms in the HPI, and individuals who have lighter skin are thought to have more positive descriptors in the HPI. So thinking about how that leads to bias from the individual that's reading it. Distinguish race from genetics ancestry, ensure treatment plans are inclusive, and then in identifying diagnosis, use social determinants and race appropriately to identify the treatment pathway. So something that I do always get asked is, what can we do what are some methods that are low effort, high impact that we can make for a more inclusive environment? So, making an overall cultural shift is a really big task. So making these little changes, one of the first things that I say is to make a more equitable culture and try to break down your biases is to learn everybody's names and to learn how to pronounce them and the origins of their name. Using implicit bias training, trying to increase representation in both frontline and C-suite positions, do ongoing DEIA trainings, and ICHP is a great venue to have, and it provides great programming that supports inclusive initiatives, using accessibility tools like closed captioning, going gender neutral, providing teaching materials in a diversity of formats, consider application processes, seek to address the underrepresentation of underrepresented populations in teaching materials, celebrate the diversity of individuals' holidays and celebrations, so have a multi-holiday calendar, promote the delivery of inclusive cases, remove the race from the HPI, and then be an advocate. Some ways that we can reduce implicit bias are to practice mindfulness every day, self-awareness training, so journaling, or just taking 2 minutes to think about, is there something I could have done differently today to be more perceptive in how we handle interpersonal relationships in the future. Thinking about identifying goals that promote fairness and equality. Stereotype replacement. So, aim to replace stereotypical thoughts or responses with non-stereotypical ones, and then counter stereotyping imaging. So imagine out-group members who have an opposite characteristic of a preconceived stereotype in an effort to break associations and notions. So which of the following best describes an example of systemic racism in which one can challenge to improve health equity, challenge oneself to assess and reflect on biases, ignore social determinants, utilize race-based algorithms, and practice stereotyping? So we can open the poll. We can close the poll. And certainly it is A, where you want to challenge yourself to assess and reflect on your own implicit bias. Now, we have all taken, most of us know the oath of the pharmacist, and something that I think is important to recognize with the oath of the pharmacist is a couple years ago, American Heart Association actually changed American Pharmacists Association changed the oath of a pharmacist to also include this statement: I will promote inclusion, embrace diversity, and advocate for justice to advance health equity. And so part of this is starting with ourselves and working on our implicit biases. Our key takeaways are there. And here is a bibliography of resources, and I would be happy to take any questions. I see a couple of comments in the chat, and I can address those. I certainly think that, the attitudes that pre-exist right now about fear of vaccination, and those kind of things are not necessarily, those are also biases, but but they're due to, again, this environment and the culture that exists. So we do know that there is a lot of politicized messaging going on about healthcare in general right now and what individuals should do. And it is a really unique time and a little bit of a scary time in a culture and in our culture and as healthcare providers, because we have to be able to navigate in an empathetic and professional way when we don't agree with what is being politicized. And, internally, when our preferences or our recommendations as healthcare practitioners differ from what is being represented in the media or by the government. And so navigating those conversations is really, really important, because I do think that those are reinforced, and then that causes fear. And those cultural messages that are existing in those spheres are leading to bias, where individuals do think, well, the government is saying this, so the government must know, or vaccines aren't safe, and therefore. So, I think that as pharmacists, we have a really unique opportunity as the most accessible healthcare professional to our community to kind of dismantle a little bit of that messaging and navigate and communicate that messaging or to our patients, to make sure that they recognize that, while messaging externally may be portrayed in one way, we as healthcare practitioners believe that these are the recommendations you should follow.
Lots of thanks in the chat. And again, I echo that as well. Thank you so much, Lalita, for being here and sharing your expertise. Every time I listen to one of these presentations, I take home something new, and I really appreciate that.
Thank you so much.
Everybody have a great day.